So what we are trying to do here, we have given some of the controversial topics in which we do not have consensus. So before we go into that, I'll just give you a brief overview of kind of work we do in pediatric cataract surgery. And as all of us know that in children, the the child size is different from the adult size in the respect that the scleral rigidity will be low. So while operating, you need to have some extra skills. Anterior capsular access will not be as smooth as it is in adult cataracts. It is more elastic, and we need to control the size of it. And it's a growing eye, so again, we need the decisions in pediatric cataract surgery are difficult due to these issues. So surgical decision making, it is generally based on the following factors, whether like the location of the cataract, status of the fellow eye. If the cataract is significant, then only we need to operate, because we have to be sure that it is amblyogenic. Sometimes very small opacities in the visual axis, we may just leave it and keep following it over a period of time. Status of the fellow eye, it will depend. If it is a very young child, whether we will implant an IOL or not. Age of the patient, that again is important in decisions regarding IOL. Presence of strabismus, nystagmus, that is important for explaining the prognosis to the parents before we operate. So surgical options available to us are lensectomy, then in very young children, lens aspiration with IOL, with pars plana, with primary posterior capsular access, and anterior vitrectomy is the most common procedure what we do in children. And in very old children, in older children, maybe around 8 to 9 years and above, we do just lens aspiration and IOL implantation. So let's come to lensectomy first. And as we all know, it is done in, we prefer to do it mainly in infants. And very important that the fitness for general anesthesia should be there. And for anterior segment surgeons, we can use both the routes, either a pars plana route or a limbal route. For anterior segment surgeons, we generally tend to prefer the limbal route more. And what we do, this is an old video, now we have switched to 23 gauge cutter. So with the cutter, just make a hole in the anterior capsule, and it should be good, large enough so that future capsular phimosis doesn't occur. And we should leave a very thin rim for future IOL implantation. After the cortical aspiration, go ahead with cutting the whole of posterior capsule and do a anterior vitrectomy so that the cells don't proliferate on the anterior vitreous face. Now this video will cover 2-3 issues together. One is sometimes we get small pupil in children, we don't dilate, a total cataract, and in this case we had the trypan blue leaking to the vitreous cavity, so the red glow went off. So what we did, we used a Grishaver iris hooks to dilate the pupil. After the initial nick on the anterior capsule, you would have noticed that the cortex started oozing out. So we aspirated the cortex first and then completed the rhexis. Pointer. And by this time the red glow is gone, so we did a IOL implantation. And now many of us have switched to using the 23 gauge cutter for posterior capsular access rather than a manual posterior capsular access, because again it is easier to do, saves time, and 100% of the IOL can be implanted in the bag when you are doing manual access, and if it extends, probably we may not be able to implant the IOL in the bag. So with the cutter, and now once we have cut done the anterior vitrectomy, you start getting the red glow again. Hooks were removed and the surgery is complete. So this is the procedure we tend to do in most of our cases. This is a significant portion of the children which we will operate, and most of them present in a different way. As in this case, you see there is a opening in the anterior capsule. So we tried to, and our aim will always be to try to implant the IOL in the bag. So the procedure, the steps we follow has to be in that direction. Try to open the existing opening and saw that if we do the rhexis at this stage, it may extend. So with the available opening, we did the cortical aspiration. And after the aspiration is complete, the opening is not big enough for the IOL to be implanted. At this stage, we used Vanna scissors to make a nick on both sides of the anterior capsule opening, and try to get a respectable anterior capsular rhexis. And we need to know about traumatic pediatric cataract because again, it forms a significant portion of the children who are having cataract. And especially if you are practicing close to a rural or semi-urban area, the incidence is more. So now we have a good size anterior rhexis. The lens is implanted in the bag. Choice of the lens, either a single piece, 3 piece, depends on your comfort level, but more importantly, we should be using hydrophobic material in children rather than hydrophilic. And again, the same posterior capsular rhexis with using a cutter. This is again about almost, if you have a unilateral cataract, you should consider this because almost 9 to 10% of these children will have posterior lenticonus. And this is a classical posterior lenticonus, what you'll see preoperatively. So important thing is that you have to be aware that the posterior capsule is open. If we do a hydrodissection in these cases, the vitreous may prolapse before the cortical aspiration. So 2-3 tricks I would say. One is a larger rhexis because we are doing a cortical aspiration without hydrodissection, so it becomes easier. No hydrodissection, try cortical aspiration from the periphery, leave the central portion for the last, and if you do it in a nice way, the vitreous doesn't prolapse at all and the posterior anterior vitreous face is intact. As you can see, I'm removing only the peripheral cortex, leaving the center for the last. And now the central, and now in the center you can see this is the posterior capsular pre-existing dehiscence in the posterior capsule. If we had disturbed this, then it would have been a mess. And after this, do not decompress the anterior chamber. Treat it like an adult posterior polar cataract. That is an easier way to explain it. And after IOL implantation, the anterior vitrectomy is done and the posterior capsular opening is enlarged as we do in normal cases. When we have done lensectomy in children, we will have to do a secondary IOL implantation later on, and that will be maybe around what I prefer depending on their compliance with spectacles. If they are compliant with spectacles, we can delay it, but if they are not compliant, I tend to do it around 2 years of age. So in this, many times you will get adhesion between the capsular rim and the iris. Since this probably was a traumatic case, the adhesion is more. Otherwise, more or less, they are neat cases with no adhesion. What we have to do, just if it is capsular phimosis has occurred, do a IOL implantation in the sulcus and then again open the capsular rim and make the capsular rim large. In this, we had a tough time removing the synechia, and then the lens was implanted in the sulcus. So this is again, when we are doing pediatric cataract surgery, we have to be aware of this also. Thank you very much. Anyone who is interested in having videos of pediatric cataract surgery can just text me their name and address on this number, which is 98317-88820. I'll make sure that it reaches to you. Thank you.
Next. Comment on Dr. Love's talk when he mentioned about routinely doing the posterior capsulotomy with the vitrector after inserting IOL. Here, if you're very experienced, it's fine, but otherwise, when you do a rexus before implanting the IOL, you're at least sure of the status of the bag. You can even implant a sulcus IOL, which is a 3-piece. But when you do, in the bag, you do a single piece, and then if some problem happens, it's a very messy job. So you have to be very careful when you're putting an IOL before you do a posterior capsulotomy with a cutter. So now we go to this topic of today. Earliest age, it's a very, very narrow, small topic which Dr. Love has given for IOL implantation in unilateral and bilateral infantile cataracts. So why this question at all? So there are a lot of dilemmas and controversies when it comes to managing children with cataract. So as Dr. Love was telling, there are a lot of differences between adult versus pediatric. Now we have crossed a long way, almost about 30 years into pediatric cataract surgeries. Now comes pediatric versus infantile, which is totally different. Pediatric eyes, in the sense we mean more than 2-year-olds. So infantile cataracts behave very differently in the way they present and in the way we manage. And unilateral versus bilateral, they vary especially with the time of surgery. Non-surgical versus surgical is always a controversy in some situations. Whether to put IOL or no IOL is always the controversy in infantile cataracts. And early versus late, and how early is early. So these are dilemmas which all pediatric cataract surgeons face every day. So is there any consensus then? Do we have a consensus? Of course we do. So there are a lot of researches and studies and standards which almost have come like a protocol when we manage pediatric cataracts. So primary IOL implantation is the standard of care for children above 2 years of age, which is well established. IOL calculations based on SRK2, Holiday, Hoffer-Q, whichever works best for you can be used. The target refraction, you have to aim for a hyperopia up to the age of 8 years, proportionate to the age, and there are various standards which probably individual surgeons prefer. And IOL type, the PMMA lenses have been largely replaced by acrylic single piece or 3-piece based on where you place the lens. And IOL placement, as Dr. Love said, it's always the aim is to place the lens in the bag. And posterior capsular rexus with anterior vitrectomy at least up to the age of maybe 6 to 8, depending on how you think the child may cooperate for a YAG if required later. Then where lies the controversy? Here comes the controversy, infantile versus pediatric. So how is a pediatric cataract differ from an infantile cataract? So the maximum myopic shift in a child's eye is said to be up to 24 months of age. And associated conditions like microcornea, persistent fetal vasculature are all common in this infantile age group. And surgical expertise may be slightly more challenging when you have to manage such a small eye. And anesthesia issues, obviously. So you don't want multiple surgeries. And otherwise, also etiology, laterality, age of onset of the cataract, how long the cataract has been there, visual deprivation, whether to operate, when, who operates, IOL or not, inflammatory response may be much more in younger children compared to older children, and post-surgery care, which is much longer. So whether to operate or not, is this a question? Definitely. When do we face these situations? So when there are no symptoms, can a child with cataract have no symptoms? Definitely. There can be very small dot-like opacities in the center, which does not affect the vision, at least by indirect evidence like following light, no nystagmus, no strabismus. So we do have a situation where we can probably wait and watch. And bilateral, symmetric, partial cataracts, and no secondary effects. So the secondary effects like nystagmus, strabismus, anisometropia, all those give us, probably maybe you can decide whether to, here there is a controversy. And some of the cataracts in children, very young children, may be non-progressive opacities. So you can watch them. So non-surgical management, is there a role? Definitely. When cataract is probably only one of the many problems the eye might have. There may be a high anisometropia associated. There may be strabismus in cataract may not be proportionate to the visual loss. There may be a corneal opacity of the visual axis or a macular pathology. So when you have multiple problems and cataract is part of the problem, you can wait and do maybe a non-surgical management to begin with, like giving dilatation drops, patching, glasses, etc. And then when you decide that cataract may be the reason and cataract may improve the vision, you can do the surgery. So if surgery, then when? This is the big question now. So indications for early surgery, In unilateral cataracts, this is again almost well established that 8 weeks probably is the critical period. Asymmetric cataract, again 8 weeks. Bilateral dense cataract, 3 to 4 months, like 12 weeks and above. Secondary effects if nystagmus strabismus is present, then early surgery. So early surgery, what does it mean? Is it aphakia? Is it early surgery to remove the visual deprivation is what is established so far. So do you leave the child aphakic and fit contact lens, or do you plan a primary intraocular lens? So when you decide this, what do you have to take into account? Again, age of the child. DBR surprises, myopic shift is very common the younger the child. Laterality of the cataract, high anisometropia following surgery is sometimes is a very bad challenge. Like you may have a hyperopia after you do a cataract surgery of +8. The other eye may be clear lens with a high minus number, especially children with ROP and things like that. So that again is a challenge. You don't know whether you operated early and did good or not. Corneal diameter is a very crucial parameter, and axial length. So what we already know in children when we plan IOL implantation in infants. So the physical parameters, these are strict rules. Corneal diameter has to be more than 10 millimeters. Intraocular pressure has to be normal. We always have to do an pre-operative on-table assessment of all these issues before you go into the surgery. Absent angle anomalies by gonioscopy, and axial length at least 16 millimeters. So IOL calculation, again in infants, you can choose any of the standard ones. Hofer Q maybe for smaller eyes. Again, you still end up with surprises despite being very meticulous in this. So if you do a bilateral surgery, you always do the refraction after you do one surgery so that you don't end up with a similar surprise in the other eye. Maybe you can redo the DBR if you find any problem. And here one more point is keratometry. Keratometry in children, the younger the eyes, the difference in the keratometry really influence the IOL power. So that also you have to take into account. Target refraction, there are various standards. Age above 2 to 4, undercorrect by 10%, and less than 2 years, undercorrect by 20%. So IATS has given us guidelines like less than 6 months, moderate hyperopia of 3 to 7 diopters you can aim for, and 12 months, mild hyperopia of 3 diopters you can aim for. So 4 to 6 weeks, children also, they have tried IOL implantation. Up to 8 diopters you need to undercorrect, and above 6 weeks, 6 months, 6 diopters. So choice of the IOL, there are no major choices. Hydrophilic acrylic single piece in the bag. In infants, it is advisable that IOL implantation has to be in the bag. There is probably, you can say that no role of sulcus IOLs to avoid glaucoma and iris adhesion and etc. You may face a situation where one eye you have implanted an IOL in the bag, and for some reason if you have a problem and you don't get the bag, then maybe a sulcus 3-piece lens you can consider, but primary plan, it should be if you do the first surgery and you, in a 2-3 months old baby, and you end up having you lose the bag, then better to leave the child aphakic and take up for a secondary IOL later. So steps of surgery is routine, general anesthesia, scleral tunnel is preferred, at least in our institute we use only scleral tunnel. Anterior capsular rhexis of at least 6 to 8 mm, cortical aspiration usual method, posterior capsular rhexis is mandatory, at least 4 mm opening with limited anterior vitrectomy, in the bag IOL placement, and suturing of the wound. So these are simple steps, a scleral tunnel versus corneal tunnel. Sometimes if you feel there is a risk to glaucoma, maybe you can consider corneal tunnel in a very small child, but generally sclera is more rigid compared to the cornea, and infants' eyes are much more softer, so you prefer for better wound apposition and healing, you prefer a scleral tunnel. So anterior capsule management is the challenge, because that is the one thing you need to implant the IOL either in the bag or in the sulcus. So the routine steps, you flatten the anterior capsule with the highest viscoelastic, you stain the capsule always, use a forceps, either a Utrata forceps or a 23 gauge forceps, make a round rhexis, and then cortical aspiration in the usual way. So here there is no major difference compared to adult. Ideally, what we can do is you can do the management of all the entire cataract up to the anterior rexus and posterior rexus through the bilateral side ports only and not open the section. You can use a bimanual cannula and aspirate the lens. So in case you are not able to retain the bag, at least you don't have to make an extra central opening. So instead of Uttrata forceps, you can prefer to use a side entry forceps for the capsular rexus forceps, which is very good. And if you're not able to, in case, get an IOL bag integrity, then you can always leave the child aphakic at that point with only 2 openings. And PPC is a must, since we know that rate of PCO is extremely high, almost 100% if you don't do PPC, and even if you do PPC, the rate of proliferation of the lens material, whatever is remaining, is very high, especially when you implant lens, since you leave a gap between the capsules for the lens to proliferate. So we normally do it with a cutter or with manual we do, so that we are very sure about the posterior capsule, and then implant an IOL. So is it over? Surgery is only the first step, as we all know. So appropriate glasses for infants is very important. Single vision glasses for near is prescribed up to the age of 1 year, depending on how active the child is, visually active. Less than 2 years, single vision for 1 meter distance. So you can give single vision glasses up to the age of 1.5 years, but correct for near and not distance. Only distance correction for an infant is useless. And more than 2 years, you need to start bifocals, parallel amblyopia treatment, and IOP assessment lifelong. So this is a very good survey on evaluating the evidence for and against IOLs in infant and children. So this is what the controversy is today. So IITS has come out with its 5-year data also. So it's a very good randomized multicentric trial of infants operated between 1 to 6 months, equal number of children in the contact lens and IOL group, and equally strictly matched in all possible ways. And they have a follow-up data of up to 1 year and 5 years. And there is a similar study of IOL under 2 cohort study. So this is a prospective but non-randomized 250 children with median age of IOL implantation at 9.2 weeks, and they have a follow-up only up to 1 year. So what these 2 studies tell us? So contact lens group IOL IITS at 1 year says visual outcome is comparable. Adverse events are less 25% as compared to adverse events in 77% in the IOL group. By adverse events, they mean requiring another surgery like posterior capsule opacity. Can you please on it? So additional surgeries are very less compared to IOL group, where the high as high as that 63%, whereas additional surgeries were only 12% in the contact lens group. Intraop complications are 11% in the CL group, because we need only 2 openings, and intraop complications are as high as 28% in the IOL group. So at 4.5 years also, visual outcome is comparable. Adverse events increase in the contact lens group, but it is significantly less compared to the IOL group. Additional surgeries are significantly higher in the IOL group, and glaucoma is comparable under age and smaller corneas, and it is not connected to whether the contact lens is implanted or IOL is implanted. So PCO, this is how it presents, and it's very tough to manage if it is a child under 2 years. You have to do the surgery. So IOL 2 under 2 cohort study says primary IOL under older children, large corneas associated with less anomalies do well. Intraop complications more in the IOL group according to this also, and glaucoma is more in younger patients, and resurgery is more in the IOL group. So what do we finally come to? So early surgery does not necessarily translate into early IOL implantation. It just means visual axis clarity. Primary IOL implantation in unilateral cases, 6 months is standard. Less than 6 months is very, very controversial still, better to avoid. Bilateral, above 8 months, you can safely implant an IOL. And choice of IOL is, as we discussed, steps to prevent capsular opacification is mandatory. And timely correction of residual hyperopia with near add goes a long way, and amblyopia management as long as required. Proper timing of secondary IOL implantation around 3 to 4 years of age is recommended if you leave the child aphakic. Thank you.
Thank you, Dr. Kavita. And next we have none other than Dr. Sudarshan Khokar, and he will be, with his vast experience, he will be explaining about myopic shift and what ideal IOL to be implanted in children. Anyone, if you have questions in between, we can have a discussion. Yeah, Kanaya.
So I think I'll start the question.
Okay.
I think I don't believe the IATS study at all. How many people believe in that? Right, one. How many people are actually doing pediatric cataracts? Okay, so for 4 and 3. See, there's gross mistakes in the IATS study. Okay, so what they've done is, I mean, you can't compare oranges with the apples. And the other thing is that surgeons they've recruited were not trained for IOL implantation. They used to put the lens in, and when they recorded the surgery, they saw the surgeries, and in some of the patients, they decided that this patient has a PHPV. That means the clinically pre-op evaluations also were not done properly.
And even the steroid use was less.
Yeah, in the post-op. So pre-op selections was wrong. It was unethical study because they had to hold the patients for at least a year and a half till the number of patients were achieved. So that means unilateral cataracts were held back and not given surgery just to complete the number. That was pre-op, an ethical thing. Post-op, as Love Guru mentioned that they gave steroid 4 times a day for both the groups. Right, if you've gone from a 2 entry and done a vitrectomy, lensectomy, 4 times steroids might be good enough. But when you put an implant, which everybody knows is a foreign body, and which I will react how, and you touch the iris, because these surgeons, according to them, were not all trained for that. So 4 times steroids is not right in that one. Follow-up, pre-op workup, when they did the axial length, in some patients they did axial length with the emulsion, and other ones they did with a contact. So there was big fallacy. So I'm going to cover that bit of the axial length. Right, so I think I'll start my talk now. So topic given to me was IOL selection, which I think Kavita has stepped on my toes. She's already told you that, so I will not go there. The most important thing, how do you decide what is the power you're going to use at what age? So I think that's what we're going to talk. So these are the eyes which at birth are 17 millimeter, and they go to 24 by the age 2 years and plus, maybe when they become adult. So obviously we all know the eye grows, but how much? God knows. Why should we go into that? Pick up the power and put in the lens right away for the emmetropia. So you don't need any spectacles, glasses, less chance of amblyopia. But on the other hand, since we know the eyes are going to grow, how much are they going to grow? My surgeons in Delhi Ophthalmic Society, one of the guys says, I want to put emmetropic power for all the kids. When they grow up, they'll be myopic. I have an elastic machine. I can put ICLs. I can do it. But can you control that? If it goes to minus 20, minus 30, I mean, you can't do it, right? So you have to have a formula. So it's like hitting a target. You're doing adult cataract surgery. It's a fixed target. You go there and you shoot. Chances are you'll hit it. What about the pediatric eye? No, pediatric eye is not the same as adult eye, and this is growing. This eye is growing. You know, the target's moving, and he shoots and he misses. So you have a plus minus 6, 7 diopter, so you missed it. Now, after this course, this guy has become smarter. So what he's seen that, okay, now this growth is good, so my target should be a little away from where I should shoot. And he doesn't shoot one palette, he shoots multiple palettes. So that means for the same situation, you can have plus minus 2, plus minus 2, or plus minus 4. So it all depends what you want. If this idea goes to your mind, my work is done. So we're trying to chase the eye which is growing. It's a moving target. And that's the only video I have. Rest is all boring stuff, so don't clap. So what is the refractive development of the human eye? When the kid is born, the old concept said the kids are hypermetropic. That was what was taught to us during the MBBS 79-80. It's all wrong, because there was a bigger study which Gordon et al. Did, in which they found out that the kids born in nursery were about 0.4 to minus 0.5. And that's about it. That means they were almost emmetropic, right? They couldn't see for the near, they only could see for near because the muscle tone was larger. And as the kids grew, the demand for the distance, they started stepping out of the house, playing out, it increased, and thus the things changed. So there's an emmetropization. The cornea, which is steeper, starts going flatter. Axial length, which is smaller, starts increasing. And along with that, the power of the lens changes. So in a child which is newborn, every lens has a constant. So your human lens has a constant. So this was the first study in which they found out that the A constant of that particular kids at that group was 116.4. This has been published about in 1980s, 85. I think most of the people have not read this article. So if you get a chance, and if you need the article, I can mail it down. And it's a beautifully written article. I think everybody should read this. Okay, so this is what they found out. There are 3 phases for the growth. So the eye actually is increasing. Axial length is increasing with the age. First spurt, then flattens out, and then flattens out further. And similarly, the keratometry goes the opposite way, thus keeping the refractive status. Now, this is what I think, Viraj, you mentioned yesterday also. What they found was in the premature kids, the axial length they picked up in these kids in the nursery was 15.1, roughly 15, 16, whereas newborns at 1, 19, or 20. So this was the data. The SRK formula which they use, the keratometry is given in all these kits. The SRK formula which you can use to change this lens, in case you have to replace the lens, gave you these powers which are mentioned here, and the refractive status was this one, right? So what does it mean? Can we have a formula based on that in which you have a linear diagram and you can just extrapolate the exit length, put the exit length and age, and you get a formula? On the basis of that, Scott McClatty came out with a formula which looked very simple. You have a line which is going in the center, and plus minus both the side you can do it. But you see, it's not that constant. Most of these spots are still outside the two standard deviation, so that means it's not going to work. They basically based it on the fact that if patient is faking and they put in a lens, the power of the eye changes, and the power of the lens per se in the eye is also changing. So it's the cornea, the exit length, and the lens power. So these three things, the third thing has become more important, because once you take this lens out of the eye, patient is phakic, this third factor has been taken out. And you want to replace it with a lens which you think you're doing better than what God made. I think it's wrong, because that's a dynamic thing, is changing. Your power is not going to change until unless the eye grows. So lens becomes constant after the surgery, where it has been before. From birth, 34 till, say, 3 years, 4 years, it goes to 18. So there's a shift. And they found that the pseudophakic eyes shift a little larger. So this is the age which, with the age, the growth is seen. The growth in the initial few weeks is very high. It's about 0.18 millimeter per week versus 0.4 millimeter per year after 2 years. So there's so much a difference. So that means the kids from 0 month to 6 months are going to grow the fastest. And this is what the Wilson paper also said. In the first 6 months, it's 0.6 to 0.6 millimeter per month till 6 months. So 0.6 into 6 becomes 3.6. So that means your eye is going to grow from 0 to 3.6 millimeter in exit length in the first 6 months. So that is where, if you want to shoot this flying clay parrot, you've got to be very, very careful what you're choosing, and you can burn your fingers. So 6 months you can wait, and after that the growth is going to be slowed down. And in the bilateral cases you can wait. What happens in unilateral, what Kavita rightly said, you have to put an implant, there's no option. So you have formulas. I'll come to the formulas a little in the late. I've got 9 minutes left. Oh, ample. So there we go. So what are the factors which are going to change your growth, right? Age at surgery. The earlier you operate these kids, the more chances of eye growing. IOL versus phakic group, which Kavita touched upon. Rigid lens versus foldable lens. A unilateral or a bilateral case. Rehabilitation, if the child is not being rehabilitated unilateral, the eye is going to be scot-free. It can go wherever. It can go longer, it can go shorter. I'll come to a few studies. And if the patient has a glaucoma, these eyes are not normalized. They're going to be stretching more, and you're going to have bigger exit length shift in these patients. And genetics. We can't pick up the data from the Caucasian eyes and put onto eyes. We did over 12 years back. We picked all the data from Dahan. We thought we'll just use the same. But we realized that our eyes were hyperopic. They're not going back. 20% for 1 to 2 years, and I think 10% for after 2 years. It's too much of a undercorrection. So age, this was a paper by Wasawa et al. In which they found out if you do the surgery less than 1 year, the shift is higher, and rightly so, because this eye is still growing. Less than 3 years it's less, and less than 10 years it's still growing, but it's even lesser, so it's 4.3%. So the earlier you do, the more chances of you missing out the target. So that's why you've got to be careful there. Now, if you've done one eye surgery and the other eye is having a normal eye, so there was a studies in which different people come out with everything. I think I'll just come to the gist of that. Now, this is what the gist is. The first paper, which came in 1996 by Lambert et al., they found out that the other eye, the operated eye growth retards, exit length retards. This was done in the rhesus monkeys, not in the human eye. So once they put this in the human eye, they realized that it's not the same. Although it was reduction, but it was not that much, that significant. And all the other articles after that said either does not change or exit length goes faster. So the eyes which are smaller or eyes which are bigger, myopic to begin with, those will grow faster, and they can actually overshoot the normal population growth. Right? Is that clear what I'm saying? Okay. All right, so this is the IATS study in which they found out that the change in both the eyes was about 0.6 millimeter. But then there are fallacies here, because in some of the patients they use emulsion, in the other they use contact, and the error with the emulsion to contact itself is about 0.3 millimeter. So if you have a 0.6 there, 50% has gone out. I don't know how you're reading this chart, so there's something grossly wrong with that. So I don't believe into that. What they said the cause for increase in the exit length with the IOL group is because they said there's inflammation and more prostaglandin release, which causes altered growth. Nobody has tested it, it's just a hypothesis. Okay. And they said because the secondary glaucoma is more in these eyes, thus they're going to grow more. I don't know. I don't believe in this one. Okay. So this was the paper which I think Kavita also mentioned, that they sent a questionnaire, the Wilson group sent a questionnaire to the group of ASCRS, which was the adult cataract, and APOS, which is the people who manage the pediatric cataract. So this was the outcome. So if you have 6 months, this is what they're doing. So they're doing undercorrection by a high amount of hyperopia. That means it's a high hyperopia to +6 to +8 is what they're looking at as a residual. If you go to the group between 12 months to 1 year, about 1 year, they had moderate, about 4 to 6, and less than that, they want almost a little emetropia or a little hyperopia +3 is fine. Now, this is what they have planned. Okay. She mentioned about the IOLs. Now, if you put a rigid IOLs, does these eyes grow more? Because there was a study in which they put in this study, they put a ring inside the eye, CTR, and they found out these exit lengths not growing. So that means akin to a lens which is a PMMA lens, which actually works like a rigid and pushing the silly body to the sides. But these are the studies which are very few. This again is a very old study and done in the rabbit's eye, so you can't actually extrapolate, but they found out that in lower animals like in rhesus monkeys and rabbits, the growth was not as good. When it comes to human eyes, these growths are more. So if you put a PMMA lenses, the eye is going to grow out of proportion as compared to if you put in a foldable lenses. All right, unilateral I talked about. Now, this is what Dahan said, that, okay, I'm going to be having less than 2 years, 20%, and 2 to 8 years, 10%. Who does 10% in 2 to 8? I mean, I think nobody has heard about that. But this was the guy who could finish it first. And the choice of lens was also different. I'll come to that paper also a little later. And then Frost also jumped in. He said, okay, let's divide out of 2. Let's make 3 groups. 1 to 2 is 20%, 2 to 4 is 15%, 4 to 8 is 10%. Again, it's very high. I mean, I will not do for 4 years. I might go as close to emetropia as possible, not 10%. 10% too high. So there was the simplest one for the beginners, N-Blardy's formula. So what? Age of the patient and refractive error is 7, lucky 7, but not lucky for all the kids. This also works well for the exit length in a Gaussian curve. If you take 2 standard deviation off, it's not going to work. So these are statistics. So if it falls in the middle, all the formulas are as good as other formula. But you can't predict a growth because there's a genetic factor, there's a rehabilitation factor, glasses usage, amblyopia treatment, you name it. The more you dwell into this, you get more confused actually. So I have stopped reading now. I just do the surgeries, I follow my patient. Now I'm going to tell you what we do at the RP Center. Now this study came, again, Scott Lambert, in which they did not undercorrect the kids from 2 to 6 years, which as such we say you should not be doing too much of undercorrection. So this is a paper which tells it works against the Dahans and Prost. They said that if you take the kids from 2 to 6 years and follow them for 2 years after surgery, these eyes do not grow significantly. That means the refractive error does not change much. So that's what we follow now. N-Bodies, this paper, and our own. So what we realize is that more than 5 years, we do not do any undercorrection. 2 years, do 5%. At 5 years, do 2%. 2, 5, 5, 2, right? 1 to 2 years, 10%. That's good. 6 months to 1 year, you have moderate to high, so I need 15% undercorrection. Now, 3 months to 6 months, I divide into 2. 3 months to 6 months this is where you want 20%, not before that. And less than 3 months, it's a very, very slippery road. You've got to be very careful what you're doing because this is the one way you can get in trouble. So 3 months, less than 3 months, even if it's unilateral, you can wait for some time, and once it crosses 6 months, you can go and do it. So that way you know where you are. And this we are already sent for publication, and this was the work done for last 5 years. We got about 1,500 eyes, and this is data coming from all those patients. Okay. So besides all these, the genicity, the glaucoma, all the things will have issue. Now, choice of IOLs. Now, this was one of the first paper by Prost et al. In which they compared 4 groups. One was a PMA, second was a PMA with the heparin surface modified. They took hydrophilic and hydrophobic. They said that hydrophobic not good lens because if it touches the endothelium, it will cause more damage. Who the hell wants this to touch the endothelium anyway? I mean, what are you doing? What are you talking about? So the line says it's a low damage potential when it touches the endothelium. So whenever you read a paper, please read between the lines and you see what this gentleman is trying to tell you. So, Okay, so this is why I've put it there. And they said that there's the lowest cell which grows on the lens, which again, I think studies have shown us that the material hydrophobic is the best, I think, which Love also mentioned. Okay, this study by Basti et al. In which they found out that if you use a surface-modified PMMA, it's just an old study, PMMA surface-modified versus not, because they thought there was a lot more inflammation. But now, on the day one, if you open the eyes, they are crystal clean because what surgery you saw, you take with the bimanuals with so much of fluid going in the eye, you're taking up lots of almost all the cortex out of the eye. So there's not any reaction at all in these patients. So I don't think whether using this one is going to make a difference. And PMMA should anyway not to be used because the eye growth is not stable with you. So currently is the acrylic hydrophobic lens, which is the most preferred, which I think Kavita mentioned all the studies, so I won't go there again. So that's the lens you should use, either single piece or 3-piece. Now, single piece lenses are meant for in the bag only, and I'm going to repeat, it's meant for in the bag only. The moment you have a rent or something, please do not attempt these one in the sulcus because it's a square edge and it's going to be rubbing against the iris. Every time the child goes out, the pupil will constrict, comes inside, it will dilate. So you're rubbing iris over the square edge, which is not right. And the sulcus is bigger than the bag, so the lens won't be stable in the center. It might go off the center also. So single piece lenses, I think all the pediatric surgery if you're doing, you should have inventory in which you have a single piece and a 3-piece lens, always waiting in the OT, otherwise don't do these surgeries, please. And a good vitrectomy machine, which you saw. And if you have a sulcus, you put a 3-piece lens. 3-piece lens is a forgiving lens. You can put in the sulcus in the bag. Single piece has to go in the bag only. So even if the bag is smaller or bigger, this lens is going to adapt to the bag from 9mm to 11mm. So you decide what you want to do. Now, there's a new technique which has come, bag in the lens technique, in which they have a rexus anterior posterior equal, and you got a lens which has a gutter on the periphery. It's not available to us yet. I think Arvind, they want to start something. Mary has done lots of work on that. She claims it's a difficult surgery, lens not available, so let's not go there also. So thank you very much. So this I'm going to repeat again. If you can take, this is a carry-on message which Sudarshan liked this video, so I'm going to play it again. Now see, this gentleman is not aiming, and he doesn't know what he's doing, right? After the course, he's become smarter. He's taking everything into consideration. Okay, I've done one eye, this is the other eye of the patient, so I know, okay, this eye is this. The family was operated, and this is other kids had, right? You had 15 patients done last week, and all these had what shift. And if you notice those, they're not one pallet which hits. I always thought these shooters are very great because they're hitting with one bullet that target. It's not. It's like a burst of thing which has a standard deviation. So it's a main plus minus 2 standard deviation. That much is allowed. You can't predict more than that. And thank you very much. I'll close my talk with that.
Thank you, sir. And the next topic is difficult, but probably will be the most entertaining. And I invite Dr. S. Sudarshan for the same. He's a... So he'll be speaking on pediatric uveitic cataracts. He is a uvea consultant at Shankar Nethralaya, and I know he will do the justice to this topic. That is why he has been included in this IC.
Good morning. I don't know whether it's a warning or a compliment. So, like one Sudarshan follows the other. They say like one spit and twice shy. Probably that was the thing about the person shooting it after the other. Okay, anyway, coming back to, it is almost like coming back to English talk now for me, with so many IOLs and pediatric cataracts and things like this. Let's come back to things. So I just saw this thing somewhere. I tried, but I couldn't make it to the veterinary school. So what do you do now? So I become a pediatric ophthalmologist probably. So I keep thinking that these are the two things. Pediatricians probably, like in ophthalmology, is pediatric ophthalm, where the patients don't tell their complaints. So really, children are not young adults. Standard statement. So basically the topic is what's the consensus on IOL implantation. But for TRP ratings, probably we'll actually add about pediatric uveitic cataracts also. Pediatric uveitis in general. Uveitis in children, there are some significant characteristics. There can be some specific entities like JIA, which is not seen in adults at all, which behaves very differently compared to any other uveitic entity. The presentation is very late in children. Obviously, I told you, like the children don't come with complaints, they don't complain. White eye, leukokaria, they don't have symptoms at all. It's almost, we find out. The behavior course is chronic. but the complications are irreversible many times. Glaucoma, band-shaped keratopathy is something that can be treated if diagnosed early. The duration of disease is very long. You have a systemic association. The diagnosis is sometimes very difficult because you can't examine the child. You need actually patience for it. And you need to do EUA examination or anesthesia, ultrasound sometimes. So management has a wide range, medical, surgical, or and amblyopia obviously, which we refer to them. So the common uveitic entities are JA-associated uveitis and intermediate uveitis in children. I group them together because most of the time they blend between each other. And you have these parasitic infections, infestations, and viral infections. Children are prone to trauma. We saw them operating traumatic cataracts and other things. So probably they are more prone to sympathetic ophthalmia compared to others. And masquerades. If you don't want some kid to be like this, definitely. So going straight to JIA, uveitis associated with JA, it has a big group, JRA associated uveitis, or something called an early onset HLA-B27 associated. Among the JIA group, this is something that seems to be the more severe and more that behaves very badly post-operatively nowadays. The JRA at least also seems to be forgiving in relation to cataract surgery or IOL, but the B27, the early onset adolescent group, that's how they grouped this into the JIA group itself. They are really aggressively behaving types. The nearest DD to JIA is intermediate uveitis in children, which is also severe, which mimics JIA, but important tests like ANA and RA may actually help in differentiating them. So the pars planitis in children, we call it, and if it is associated with TBS orchid, probably it comes into the intermediate uveitis group. So what is the difference? Clinically, slit lamp, probably even BSK can be sometimes very leading you to the diagnosis. If it is in the interpalpebral area, then usually it is JIA. If it is in the girdles, it is IU, intermediate uveitis. I keep telling it is not something statistically significant or anything, but that's the observation we usually see. If you have a BSK in the girdles, then probably you are leaning towards intermediate uveitis. Interpalpebral area very, very typically is JIA. Okay. I keep harping upon this IU and JIA before going into the pediatric cataract per se, because these two are very similar in presentations. Only thing is, immunosuppressors, you need to be very early in JIA. Immunosuppressors as a choice has to be very early in every child with uveitis. But in India, obviously, we need to be careful about many things. We start off with steroids in any case. Now, probably biologicals is the answer for JIA. And JIA early, even in younger patients, intermediate uveitis, probably as a steroid-sparing agent you can use later on. Cataract surgery, you will have to be very cautious in JIA, but intermediate uveitis is patients tolerate it better. The prognosis always JIA is more guarded, while intermediate uveitis it is much better. Okay, cataracts in children, they are mainly due to the disease process or due to the drugs, steroids which you use, and sometimes are surgical trauma. Most of the time we keep thinking that soft cataracts, rhexis is over, everything is over, but like in children actually rhexis in front and in behind both are difficult, anterior and posterior. So you need to make sure it doesn't start off with the surgery alone in children, like in any of the uveitic cases. The preoperative preparation is very, very important. The systemic disease control is more important, especially if it is JIA. The planning before the surgery, you need to plan for amblyopia and so many other things. The intraoperative management, we saw a lot of videos about how difficult it is in children. I've also been learning posterior rhexis with Kavita. Post-operative inflammatory control, follow-up and continuing treating the disease is very important. Pre-operatively, it's very, very important that the inflammation-free period, all your post-operative outcome, everything, how you are actually you're treating a patient with uveitis, you have two big problems, a pediatric cataract, which is a big problem, managed amblyopia and other things, and pediatric uveitis, which is a chronic problem, at least for when the child grows to about 16 to 20 years. So you'll have to make sure that it's an inflammation-free period. Make sure whether cataract is a cause for the media haze or vision loss. Pediatrician clearance is very important. Sometimes you need to plan additional procedures. Just to reiterate that pediatric uveitic cataract surgery does not begin from surgery alone, unlike in adults. So as they say, well planned is half done. The surgical management in younger children, probably lens aspiration without IOL you might think of earlier, but in elderly, if you have a total cataract, if it is 2-3 year old, then obviously you don't need to plan IOL straight away. But in intermediate uveitis, they generally do better. IOL is strictly contraindicated in much, much younger JIA children because all the studies whichever have used intraocular lens in JIA have had at least about 3 to 4 years of inflammation-free period. In older children, IOL is okay, but definitely in the bag. No 3-piece in the sulcus. JIA with caution, need quiescent stage for at least 3 to 4 years. Basically, I don't know IOL consensus topic and this match, but anyway, for we also want to show off that we also do all these kind of surgeries. So basically, in uveitic cataracts, you can actually the pupil management becomes very thing. Either it can be a synovial Q lens. Sometimes you. So this is something very interesting. This is Kavita's patient. So you release the synovial and you find that there is another layer of almost like another layer of iris which you need to release it. This you find in many times of traumatic cataracts, probably when it is stuck on appearance, and in chronic uveitis or when you have an aggressive uveitic. So hooks you can use. You can either use a Grishaber or a Q lens. Most of the time, I think in children probably you prefer a Grishaber. In Q lens itself, you can have something like a larger part of it here and this one which can stretch it. It's always better to have a well-retained pupil with Grishabers. Capsule, there's no ego. Whenever you need to stain it. There's no point proving that you can do it without staining. You don't need any country's flag signs. So PPC is a must in younger children especially. But one thing about uveitic entities is whether anterior vitrectomy is required or not. I somehow believe, and we seem to be believing nowadays, that PPC is okay, but no anterior in uveitic entities. Initially, it was thought that it prevents CME and otherwise, but nowadays it seems to it seems to cause more traction when you have very limited, if you don't do the anterior vit properly. So the aim of PPC is to prevent the PCO and prevent amblyopia. So we can rest with that. The CME and other parts of it we can manage medically. Okay, the older versus younger children, obviously the controversy is always there. Risk of amblyopia is there. Consider not doing when it is in older children who are cooperative for YAG caps. So in younger children, avoid antivit because highlight phase is intact. Why do you add the risk of traction? IOL, as they say, in the bag and in the bag only. If it's not, then probably it's better off in the pouch side. So if you don't have the bag, then nowhere else, especially in uveitic. So IOL children, what literature says, there are not many studies. It is a lot of retrospective, small sample size studies only. Then probably it's an indication that we all should combine and do larger studies probably. Then there is no long-term data. Most of the studies have shown about 6 months, 9 months and 1 year follow-up, which is very, very, very less. No RCTs at all actually comparing IOL and FAK. In fact, there was a free paper yesterday by one of the PGs who had a study on IOL and FAK lensectomy and thing. So you need to definitely compare phaco and lens width. There are few studies which have showed that improved visual acuity, but median follow-up of 6 years. But this is they're not actually classified it very well. 19-20 eyes are very, very less for you to come to some kind of conclusion. Both these studies, but still stress the need for maximum control of inflammation. So we have a study actually on phacoemulsification and IOL in JIA. Surprisingly, from Shankar Netrala, we seem to be known for conservatism, but we actually did phaco IOL and JIA. And here we found that the key to success following cataract surgery in JIA was the age of the child, absence of amblyopia, and strict pre-operative and post-operative control. So it's not necessarily the visual outcome, but the inflammatory outcome was very good. All these patients were most of them were in the adolescent age groups who had at least 3 to 4 years of inflammation-free period of JIA. So that's very important. The elder age group patients of JIA and who are in the adolescent age group seem to be doing better. This is a recent review article. This was a review of studies in JOIA. Is an article very well written. But they found that most of the studies have shown poor outcome when inflammation is not controlled. That's stating the obvious. And IOL, it's a big no in some situations like where you have cyclitic membranes, hypotony and other ways. In those cases, lens width is much better. So surgery, if it's over, is it over everything? So it's not like that in uveitic. Monitor the inflammation IOP, PCO and CME is very important that you manage them. Steroids and immunosuppressors, it goes on and on nowadays with uveitic, and biological seems to be better. The perioperative dosage of steroids depends upon the disease. There have been some studies where they've injected Ozurdex with pediatric uveitic cataracts for the perioperative period. Post-op, you can have all these, hypopyon, fibrin and so many other things. But before all that, you need to decide whether if it's phaco or lens width. That's very important. So to conclude, pediatric uveitis diagnosis and management is a challenge. The cataract management, it's very important that you have a proper pre, intra and post-op follow-up. Teamwork, amblyopia therapy, and remember, masquerade. And long inflammation-free period to stress it again. Adequate perioperative cover. And in the current era with immunomodulators and biologicals, IOL is a very good option. You want to give them a pseudophakic eye. Pseudophakic has better visual outcome, less CME, and so many other things. JA with caution, but all other uveitic entities do well. Thank you.
Thank you, Sudarshan.
If you have a BSK which is growing across the cornea, those are the patients which are not going to do very well. Lots of time the patient comes with band shape which has stopped progressing, and like you said, inflammatory free zone area. Those are the patients in which you do a lens proper inside the bag, they work well, and you said rightly. We recently, we done about 150 data follow-up about 3.5 years now. So the one in which the cyclitic membrane forms again are the ones in which you don't do vitrectomy. So I think from that perspective, vitrectomy has to be done. And we're using a Centurion machine which we have a 4,000 cut. So you need to have a cut rate high and traction at the minimum. And pediatric eyes, I don't think they get the TRDs that easily. If you really have to work hard for that, because you have to really make the vitreous swell up with fluid to start coming out. Otherwise, if fluid is outside, your cutter goes and you've got a good cutter, it works pretty good actually. As compared to adults where it's just waiting to happen actually, especially in the myopic eyes. Not in the myopic, in the adult eyes, in which the vitreous base is still intact. Right? You agree with that? So, IOL power, sorry, I'll give you the mic one second. I'll give you the mic. So, inflammatory patients you can still do. And if you have a corneal opacity in the middle, you can, after putting the implant, you put in a pilocarpine dab in the eye, pupil constricts, then you take your scissors and cut an optical iridectomy in these patients, because even if your lens is in the bag, there's a central opacity, the child is not going to see from anywhere. So you need to have OIs in these patients. And I believe you cut the iris along with the frill or around, the membranes normally don't form there. So what I do in these ones which are stuck down pupil, after removing, I eat the sphincter all around it with the cutter. And I've realized that the group with which I cut the sphincter, they don't come for the VO opacity. That's my this thing on this.
Yeah, I agree with it. One thing is we try to make sure that it doesn't become a corneal opacity. I mean, like if BSK is much earlier, then we try to scrape off the BSK part of it, treat it first, and then plan cataract surgery, so that like your visual axis is otherwise okay. You don't need to meddle with the iris. The second thing is about the vitreous anterior trimming. So initially we used to be telling JAA you can use IOL with all these inflammation-free period and things like this. The moment you tell in an IC that like you can put IOL, people put IOL anywhere and everywhere.
Yes.
So
yes, the message has to be.
It's better to have that like something in your hands with a Centurion, maybe like Antwit with no traction. Yeah. But if it's better to think, if you have cyclitic membranes, you can probably do a UBM and otherwise to make sure that there are no cyclitic membranes. Then it's fine. But if it is, then yeah, lens fit is a better option.
Formation.
There have been some studies which have actually done phaco-vitrectomy. It's not like phaco with anterior vitrectomy. Right. It's phaco with a partial vitrectomy. So those things probably are much better.
Yeah, that's what I was saying. Right?
Thank you. So let's come to the last topic of this IC, and then we will have some time for discussion. So pediatric lens subluxation. How many of us are actually in favor of operating in cases of pediatric lens subluxation? So, what has happened over the years when, as more and more experience we have gained and more clinical data we have got, earlier we were very skeptical while operating a subluxated lens, because literature used to show that operating these children leads to a higher incidence of retinal detachment. But with more and more experience, that is not there. So what we know about pediatric lens subluxation, these are especially the non-traumatic ones, these are progressive, and generally when you refract these children, they will have a high myopia and a high astigmatism. And whatever you do, their vision will not improve, and it will be in the range of counting finger to 618, but generally not beyond 618. So when we operate, and when we operate this at a slightly older age-wise, we have to be a bit conservative. Don't do it very early, in maybe 6 years and beyond, or we still need to know about that. And more and more patients, we are seeing that results are good, and most of these children develop vision, and they go to almost 6'9", 6'9" or 6'12" definitely. So options that are available to us, one is preserving the capsular bag, and whether we should preserve it or we should not preserve it. I would go more in favor of preserving the capsular bag, because these are small children and they have a very long life ahead of them, and if we maintain the anatomical compartmentalization between the anterior segment and posterior segment, chances of posterior segment related complications in future will be less. So as far as possible, try to preserve the capsular bag. And if it is gross subluxation in which it is not possible, then we have an option of the SF-IOL and glued IOLs. So when we are deciding about preservation of capsular bag, the first option available to us is lens aspiration with a capsular tension ring with a MH segment and IOL implantation. So if you see, there will be 3 implants in the bag in these children. And surgery wise, definitely very demanding and need high skill for it and a lot of experience. So let's go with the surgical videos. Now here you see each case will be different, and you cannot expect the same as we have in adult cataract surgery. Adult cataract surgery nowadays runs at subcortical level, but subluxated lens can never run at subcortical level, otherwise you will end up with surprises. And what we see here, when we are aiming for rexes, we had a very small rexes, but still we used the capsular hooks and pulled the lens to the center, implanted a CTR, did a cortical aspiration, and IOL implantation in the bag. And after we have implanted the IOL and the hooks are removed, we remove the hooks and we notice that the anterior rexus is grossly decentered and small. So make a neck again, and generally they don't extend. After this stage, if you make a neck and enlarge, we fear that with the CTR in place it may extend, but generally they don't extend, and we can easily enlarge the rexus, clear the subluxated area of the vitreous, and then the MH segment is implanted. Many of us will have a choice. It depends on our skill and our preference. Some of us will prefer a Sione ring. Some of us will prefer a segment. It really doesn't make any difference, but as long as we are able to do the surgery safely. And after the MH segment is slightly stouter than the Sione ring. So pushing it in the bag, you have to lift the anterior capsular margin and then push it in the bag. And titrate the knot. I generally titrate it more towards the subluxated side so that eventually the knot loosens and then the lens stays in the center. That is one way of doing it. Second option is a lens aspiration with Sione ring and intraocular lens. So here we have just 2 implants, the Sione ring and the intraocular lens. Let's go through the video of this. Now here you see this is again a gross almost more than 180 degree subluxation. This is another way of doing the capsular rexis. After initiating, first pull the lens towards the center and then complete the rexis. Then the problem what we had in the first case of a small decentered rexis may not happen. So this is another way of doing it. And then before cortical aspiration, when this is my choice. Again, it may differ from surgeon to surgeon. I prefer to implant the Sione ring before cortical aspiration. This was my first. Initially, I was more inclined towards MH segment. This was my first case of Sione ring. And to my surprise, I could finish the surgery within almost 50% of the time when what I used to take in the MH segment. But as with more and more cases, then I started facing problem with Sione ring as well. Then again, I've gone back to MH segment. So you don't know. There's no perfect way of doing it. You have to decide case by case. And here what we did, after implanting the Sione ring, we anchored it to the sclera, so that when we are doing the cortical aspiration, the lens is more stable and we could perform the aspiration well. And it has to be tight enough. Sometimes when your suture is loose, the eyelet of the MH segment or the Sione ring can come to the visual axis. So it has to be properly tightened. And lens implanted in the bag and doing well. And you should remember that it is a progressive disease. The zonules may give way from the other side, and in future we may have to deal it with a suture along the bag. Now coming to difficult situations, that is what I told why I went back to MH segment. This was a case in which there was subluxation and the rhexis was small, and the mistake when we have different techniques to do it, we generally tend not to follow the same technique in every case. Here I forgot what I told in the first case, that implant a Sione ring before cortical aspiration. I aspirated the cortex first, and then after that when I was implanting the Sione ring, you notice that from here I could not follow this part where it was sliding from the anterior capsular margin, and it slided anterior to it, and while dialing the Sione ring, it came out of the bag, and now the ring is in the eye, in the angle and outside the bag. With small bag and such a big ring, I had to struggle for almost 20-25 minutes to put it inside the bag, dialing it in various directions. I could not do it, and just before I was planning to give it up and do a lensectomy, I dialed it in the opposite direction with a posterior push, thinking that if it gets subluxated, if the bag gets dislodged, I will just explant everything. It went inside the bag. So I was lucky here and could finish the surgery in the desired way I wanted. And many things go wrong. Sometimes the suture can get stuck here. When you are tying it, it can get entangled in the section itself. So that also I have faced, though I don't have a recorded video of that. And the lens is implanted. So again, a happy situation. Now, another situation. Yeah, here we have a situation in which after these two cases, I went back to MH segment. And then again, I landed up with a complication with MH segment. I will try Sione ring again. So in this case, what happened, after the rhexis, and sometimes generally visualization is very good, but when you have disturbed the cortical matter in the bag, then you may not be able to delineate the anterior capsular rhexis margin. And it is very important that the loop of the Sione ring should be anterior to the anterior capsular rhexis margin. So in this case, what happened that after the implantation of the ring, I did a maneuver by which I was sure that the loop is anterior, and then tied it to the sclera. But it was actually in the bag. Then with the sharp 10-0 or 9-0 proline, the anterior capsular rhexis margin ruptured. And you will, if you are able to make it out, probably somewhere in this area. Both the sutures were taken by railroad technique. And tied, and this is the stage in which it would have ruptured, but I didn't notice it. Then I did a cortical aspiration, And at the end of cortical aspiration, I noticed an area of compromised anterior capsule, and that had extended from the equator to a part of the posterior capsule also. But then what I decided to not to explant and use that Sione ring as a sulcus and then implant a 3-piece IOL in the sulcus. And luckily for me, the lens was well centered and still doing well. But long term, we don't know how these children will do. And at some stage, the IOL may get decentered and we may have to do one more procedure. But at this stage, it will become very messy, so I decided to implant the lens and observe it in future and deal it with as it happens. So this is in brief about subluxated lenses, and I would complete it at that. We have some time for discussion, and we would be happy to take questions from the audience. In children, sir?
I just said that you don't have a target to shoot. So what power you want to plan? You want to make it hyperopic, myopic? It's changing. Lens power is changing. The multifocal is not for the kids. Till 10 years, 8 to 10 years, when you think your refraction has become equal and you don't have any cylinder there. See, the cornea is changing. If there's a cylinder in the eye, multifocals you don't do, right? And if there's an amblyopia in the eye, you don't want the contrast to go down. So all the multifocals will only focus 80% of the light, 20% is thrown out of the window. So why do you want to go where, you're not sure what you're doing, and the lens power might change. So no multifocals, at least for 6 to 8 years. If to be safer, I think 10 years. Well, after that, they're as good as adults. You can do whatever you want to do, but not before that, please. Deadline, there's no deadline, right? If your size of the eye is not good, even if the guy is at 5-6 years, I can't put a lens. White to white, as Kavita said, is less than 9.5 is what I'm doing. She said 10. And the axial length is less than 16 millimeters. That means the power of lens which you need is about 45, 48, 50, which you don't have.
Yes.
So smaller eye, anterior segment of the eye, it's not built properly. There's no point in forcing a lens inside. And as you saw, all these bags are not that big. These bags are smaller. The bags also grow with the stretch. So safer 17 millimeter and 10 white to white, what Kavita said is right. If you have that, you can put in a lens, irrespective of the age. The age will be important when you calculate the power, because the eye is going to change its axial length and keratometry. So that is a different factor. But yes, you can put an implant, even if it's 3 months old kid who has 17 millimeter and above axial length and 10 white to white, because that's cornea white to white. Okay? Yeah, even if it's 6-7 years of age, it's smaller eye, you're not putting a lens. I get IFC patients a lot, so I have to leave them phakic because the white to white is 6 millimeter. Even if the axial
probably what he wants to know that if everything is in order, yes. What is in unilateral cases and bilateral cases?
In unilateral cases, you can do as soon as possible, because you don't want one eye to go into amblyopia if all these parameters are normal. Whereas in bilateral, because both eyes you have to do, you can give aphakic glasses, which is having an equal balance both eyes. Unilateral aphakic glass is not going to work, and if you have a good contact lens setting, even unilateral can be delayed. But safer will be 3 weeks, anything 4 to 8 weeks in unilateral, and 3 months onwards in bilateral, you should put implants.
So how is the acceptance for the contact lens?
Very bad. We don't have a setup in which we're giving a pediatric, because every time the patient comes, you need anesthesia to take it out and push it in. The book says, the Parks and Parks study says, you have a set of lenses which every 6 months patient comes, you change the lens, because according to the PAR. We don't have good patient compliance.
And another issue is that most of these are lower socioeconomic group. They will not be able to follow that contact lens maintaining protocol. They are not able to use it.
Yeah. So I can give you all the protocols if you want, I have with me, but the problem is they're not going to follow because they're costly lenses. The siloxane lenses, they're not cheap lenses. If you want a lens with extended wear, they're also expensive. And there's a 3.4 lenses dropping in 1 year. The studies have quoted that. That means if you have 2,000 rupees lens, 6,000 every 1 year extra cost for the patient who are poor, they won't bear it, because another 2-3 years they're going to stop using it.
Sir, for the anterior vitrectomy, do you have any experience of pars plana vitrectomy, sir?
Yeah, you can do it from both the sides, but I prefer once you've done a posterior vitrectomy and your machine is good, you can go from anterior and do it. Yes, because since you're doing a core vitrectomy, you're not going to cut the periphery all the way. You're not doing a VR surgery. But you just want that under the rexus margin, 2 millimeter all the sides, you want to take the scaffold, the support away. So you can do from anterior absolutely fine if you have a good machine which doesn't have a traction, which I think Sudarshan.
And in children, generally the vitreous doesn't prolapse. See, pars plana, it's always preferable when we are expecting the vitreous to prolapse, then it is causes less complication. But in children, if it is a formed vitreous, it doesn't prolapse. So we do a good anterior vitrectomy. By limbal route is good enough. Yeah, please. In India, it's not available. Again, that if depending on the wide to wide diameter, we can go for a smaller IOLs, but I don't think. Yeah.
Sir, in that relation to the pars plana vitrectomy, I think I have just one point that when you are starting to operate, when you're not very experienced and you're operating children, especially below 1 year, and you're aiming for an IOL, maybe it may be a better idea to put an in-the-bag IOL so that your aim is achieved and then you go pars plana and do a vitrectorexis and a vitrectomy. So in that situation, I would definitely prefer a pars plana approach over a limbal approach.
Can I ask one question? Like it is related to the, it's a 6-month-old child, bilateral aphakic. It's the average socioeconomic status. What should be the way of?
Comfortably doing everything. The only problem is that his glasses are heavy. So by 6 months you have a facial structure which are formed, the nose bridge, the patient starts sitting up. The problem is the kids who are toddlers, who are on the bed, who you not even have the bilateral cataract, say a month, 1 month old, you put aphakic glasses, the patient can't hold the head. The weight of the glasses is more than the head of the baby actually. But 6 months I think is a good time. If you're safer and if your excellent is you following the patients up, your refraction is you following, 2 years is a very good time to put in whenever the refraction becomes stable. But it's not going to become stable, but the growth is going to go slower. So 6 months to 1 year, I'll do it at 6 months, but I'll suggest people that if the patient is having glasses and falling, you can follow safely till 2 years, and then you can go ahead. So whatever posterior capsule fasciculation has to form, they'll form by 2 years. Then you go and cut that membrane out from the inside out and make a sulcus and put a 3-piece lens.
Sir, in your hands, IOL at 3 months, 6 months will do well. But again,
I just said that. So you can wait till 2 years and you can go ahead. Please don't follow whatever we said. What he showed about subluxation was a very dicey slides. I wouldn't have shown you those videos, and I would have done it differently. But yeah, if you've seen that it's not very easy. In the beginning, I think 99% you'll either the rexus runs off because it's mobile. You can't hold it because the moment you puncture it, it's actually flattens. You have the wrinklings on the capsule. So all the dynamics are different. So it takes you lots practice on that one. And he's shown you a beautiful thing. The thing which I differ with him is I don't use the capsular hooks because capsular hook I found are very big. Sometimes it tears the equator of the lens. So I use Grishaber iris hooks on the lens margin. So that's fine. I think that's good. And I don't use 2. If this is a big luxation, I can use 3, 4, 5. So I have everything stable. I put in my Helon, make the bag big, put in my Sione, then remove the hooks. You're having a problem because you got 2 hooks. So your actually fulcrum was at that and it was moving. It was, fixation was 2 point. So if you have 3, 4 hooks all around, it's
then insertion of Sione will be more.
All the rings will be easier. Make more sense actually. But anyway, beautiful surgery. So I'll take, because I have to load the slides.
Thank you
very much.
Any more questions from the audience?
We all come to hall, we don't see the surgery.
Okay, thank you very much.